Thank you so much, everybody, for coming to the Derbyshire Education Network session, the education session tonight, and it's a joint First Five one as well. And we are very grateful to have Mr. Lee Breakwell coming to teach us about back pain tonight. So thank you so much, Mr. Breakwell, for giving up time for us this evening. And thank you so much, Amy, as well. She is our admin boss who sorted all this out for us and sent us all the emails and the links. So much thank you to you as well.
Good evening, everyone. My name is Devinda Bassan and I work for Daiichi Sankyo. Thank you for joining this session. It's a promotional session. So over the next 10 minutes, I'll briefly talk to you about Nilemdo and Nustendi, which are first-in-class oral treatments with a unique mode of action for lowering cholesterol. So what is Nilemdo and Nustendi? Basically, these are oral options that contain bempedoic acid. Nilemdo contains 180 milligrams bempedoic acid, and Nustendi over here is a combination of 180 milligrams bempedoic acid and 10 milligrams ezetimibe in one pill. Key points about where these products are best positioned. So Nilemdo and Nustendi are indicated for use in those patients who are insufficiently controlled with other oral lipid-lowering therapies. Both have a broad license indication, can be used in adults with primary hypercholesterolemia or mixed dyslipidemia as an adjunct to diet. As per license indications, Nilemdo can be used in combination with statins, with or without other oral lipid-lowering therapies, or they can be used in combination with other lipid-lowering therapies in patients who are statin intolerant or for whom a statin is contraindicated. And Nustendi here, which is a combination, according to its license indication, Nustendi can be switched to those patients who remain uncontrolled on combination of statins and ezetimibe or ezetimibe alone. So both Nilemdo and Nustendi can be initiated in primary and secondary prevention patients. You have the option to use Nilemdo and Nustendi before using injectables or referring to secondary care, as is shown here on the screen. And furthermore, I'd just like to make this point over here about the National Accelerated Access Collaborative Pathway. These are the national guidelines for lipid management. They do endorse the use of bempedoic acid and ezetimibe in primary care and does not require initiation by specialist services. However, locally in Derbyshire, these products are currently for restrictive use. They are being reviewed. How they are being used by specialists in those patients who are not being adequately controlled with their existing lipid-lowering therapies. In Nottinghamshire, both products have been approved as Amber 3, which means GPs can initiate these treatments in primary care. So in Derbyshire, we'll wait and see. Hopefully that will change. Just briefly, with regards to the key clinical efficacy and safety data, in those uncontrolled patients, when you add Nilemdo 180 milligrams once a day, it reduces LDL cholesterol significantly in the range of 17 to 28% from baseline to week 12. And then with Nustendi, there was a significant reduction in LDL by 38% from baseline at 12 weeks. In terms of safety, Nilemdo is generally well tolerated when adding to existing lipid-lowering therapies. Most common reported adverse events are hyperuricemia, pain in extremity or anemia. And with Nustendi, it's hyperuricemia or constipation. And the constipation is due to the ezetimibe there. Just like to point out two safety precautionary points. When Nilemdo and Nustendi is co-administered with simvastatin, there was a point that was made here earlier on. It was over here on this slide. The simvastatin dose should be limited to 20 milligram once a day or 40 milligrams daily maximum for those patients with severe hypercholesterolemia or those who are high risk of cardiovascular complication. This is because Nilemdo and Nustendi can increase plasma concentrations of simvastatin up to 2-fold, but this hasn't been seen with other statins. So this is why you've got that concomitant use with simvastatin over 40 milligrams as a contraindication. And in some patients, bempedoic acid can raise serum uric levels and may cause or exacerbate hyperuricemia and precipitate gout. But this is more likely to happen in those patients who are predisposed to gout in the first 4 weeks of treatment. In this situation, treatment with Nilemdo and Nustendi should be discontinued if hyperuricemia is accompanied with symptoms of gout. So I just wanted to make those precautionary points regarding simvastatin and the hyperuricemia. So just in summary, both are novel oral treatments with proven efficacy and are generally well tolerated. Nilemdo contains 180 milligrams bempedoic acid, and Nustendi contains a combination of bempedoic acid and 10 milligrams ezetimibe. It can be initiated both in primary and secondary prevention patients, and they can be taken with or without food at a time that suits the patient.
Brilliant. So shall we hand over to you, Mr. Breakwell? Is that okay?
Yes, of course. Hi, good evening, everybody. Thank you for the invite. Some of you may have been put through the pain of hearing me talk once or twice before. I've been asked to talk about back pain and subsequent management in primary care. I'm a spinal surgeon in Sheffield, working at the Northern General, the Children's Hospital and Claremont, and so I see the full range of spinal pathologies. The aim is to try and talk through what problems I see, and obviously what you see a lot more of this than I do, how to assess the patient in the time that you've got, so keeping it simple in terms of a quick algorithm for managing diagnosis and assessment and management, when to assess and how to assess the patient, and possibly of relevance hopefully is when to refer. I get that you've got limited time. I know there are pressures on you not to refer patients into secondary care. Clearly we can't cope with too many referrals, and then your patients get a poor service. So hopefully we can sort of pick our way through what to refer and perhaps when. So starting right at the top, the things that you should want to refer now. So patients with cord compression of any cause. So if you've got a patient with signs and symptoms of cord compression, you need to speak to somebody at the hospital there and then, as I'm sure you would imagine. Cord requiner syndrome, which is the thing that tends to scare most people in primary care. From your perspective, the true diagnosis is rare. You may see 1 or 2 cases of genuine cord requiner in a career, but that's in the mass of patients who report a bit of numbness, a bit of tingling, a bit of urinary symptoms associated with their back pain. And it's an absolute minefield at my end, but my end is easy because I've got a registrar to assess them and I've got an MRI scanner at the end of the corridor. So my job's easy. Your job is potentially very difficult. So hopefully I'll give you some insights as to how to pick your way through that. Spinal infection is a common and increasingly common pathology. We do a spinal MDT once a month with infectious diseases, and we discuss 20 to 25 patients every month with ongoing spinal infection in the Sheffield area. And it's very serious. It's often diagnosed late, and it can be catastrophic either in terms of neurological pain and weakness and also death if it's bad enough. So a real serious condition. So what problems occur? Well, here are some quick examples just to sort of illustrate the story. So a 66-year-old lady with interscapular back pain of 4 weeks duration. You see lots of people with back pain. Once upon a time, we used to consider thoracic back pain as a red flag in its own right. Thoracic back pain is so common that that's not really realistic, but new onset of thoracic back pain just raises the element of suspicion a little. Now, this is the key. That's the line to take home. Previous history of breast cancer. We'll come back to specific red flags in a few minutes, but that's the key word. So you may have that in your records, but you may not. So a really important question to ask in terms of red flag pathology is a previous history of carcinoma, even if it's 20 years ago. This patient's ataxic, so she's staggered into your clinic. She describes walking as if drunk and doesn't know where her feet are. So immediately you're thinking something pathological because of the breast cancer. She's got interscapular pain and she's ataxic. So she's got cord compression until proven otherwise. When you examine her, and I'll go through a quick algorithm for how you do an examination. I have half an hour in theory for a new patient, so I can strip the patient off and do the full exam. But even I rarely do that because you can hone down quite quickly if you use the algorithm of history as to what examination features you need to look for. And so a trick here would be to get her to, you hold her hands and get her to walk on her heels and on her toes, and she can't walk on her toes. So she's weak as well as ataxic. This is her scan. So this is an MRI scan showing abnormalities at the L5 vertebra and at the thoracolumbar junction. And what you can see is the bones look a different color. And you can see that the one bone, so 5, 4, 3, 2, 1, 12, 11, T10 has fractured. It's wedge shaped, and there's some sort of disease process going on around that area. And that's quite possibly pathological and probably tumor. And you can see the back of the vertebra is bulging towards the cord. So the key being previous history of breast cancer. She's got weak legs. When you examine her in detail, she's got clonus and extensor plantars, so upgoing big toe on plantar. This isn't necessarily something I would expect you to do. This is what we would do. The key for you is that history rings alarm bells. She needs to be seen today because of the ataxia, because of the new onset of pain, and she's weak. So case 2, thoracic pain again. This is a 19-year-old girl. So this is a very different scenario. This girl's had pain for about 3 months, been treated with lots of ibuprofen, and it hasn't gone away. She keeps attending to the practice with pain between the shoulder blades, and she's really miserable. She's a student. Now, this is, again, a relative red flag. She's from Somalia. She's been in Sheffield a couple of years. She's a student at the university, but she's got now a history of something that might be suggestive of infection. So she's got thoracic pain when you dig a bit deeper, thoracic pain and weight loss. And when you examine her, she's ataxic and weak. So this poor girl had been managed for several months with thoracic back pain. Nobody had thought to ask of the risk of infection. And she's got, guess what, tuberculosis. So TB is relatively rare in Sheffield. We still see a few patients from time to time, but it's not common. But of course, you get little pockets with people with travel, etc. Always think about it, and it regularly gets presented late. So this is case 3. So this is somebody who had a scan through the MSK pathway about 6 months ago. Bit of leg pain, bit of numbness in the big toe, a bit of numbness in the heel. Couldn't work as hard as he wanted to, but generally managing. 35, long-standing history of back pain, 3 separate episodes of leg pain. So you see lots of these people. People cycle with degenerative disc disease, as it's often defined as, and they struggle with pain. It comes and goes, episodic, miserable at the time, and then most of the time they're fine. He's had previous surgery, and now he's got occasional urinary problems that he describes. So how are you going to unpick this? So what he's now presenting with is worsening back pain. He's now got bilateral leg pain. That's the first time he has presented with bilateral leg pain. He's got saddle numbness. That's sometimes they offer that, but more often than not, you have to ask about that. And that's his new disc. So he's got a whopping L5S1 disc, which is filling the canal. So you may have to take my word for it, but if you look at the sagittal section on the right, you can see the white CSF all the way down, and then there's this black thing at the bottom disc. And on the left is a cross section at that level, and that shows that the whole canal is black, and that's all disc. There's no CSF there. So that's a true cauda equina compressing lesion, and he's got impending and progressive cauda equina syndrome. So this is the one thing, cauda equina. So the problem we're having at the moment is, understandably, you're all very twitchy about missing this, and patients are becoming increasingly aware of this condition. And there's lots of things out there on the internet and on Facebook, I'm sure, and people know the buttons to press. So in the 15 years I've been a consultant, the referral rate and the attendance at ED for cauda equina has gone up more than tenfold, because people know to report a bit of numbness, know to report a bit of urinary symptoms. And it's an absolute nightmare for both of us. We have to keep the patients with cauda equina safe, but we have to be able to navigate through the system, and it is difficult. So in simple terms, there are 2 types of cauda equina syndrome. It's a clinical syndrome. So the diagnosis is clinical, and then I get a scan to prove it or disprove it. So that's the key. And that's the bit that is broken in the current system. So ED regularly say, patient with back pain, a bit of urinary incontinence, that's it, cauda equina. No, it's not. Not in isolation, that's not cauda equina. You might have some suspicion, but that's not cauda equina syndrome. You've got to have more than back pain. So there are 2 types. The type that I was taught that was cauda equina is what we now consider to be complete. The chances are the nerves are dead. The chances are there's no chances of recovery, and it's too late for us and for the patient. So we don't want to arrive at that point. And then there's incomplete, which is once the patient has started to have some degree of damage to the cauda equina, their bladder function is going off, their leg motor power might be going off, and we have a ticking clock, during which time we want to try and undo that compression on the cauda equina to reverse that trajectory. Now, there's a huge medical legal world here. I don't do medical legal work. It's horrible. It's depressing. There's a lot of hawkish experts, shall we call them, who will say that there's a linear progression from the first onset of symptoms to complete, and therefore you've got X hours to operate, and every hour equals 5% culpability on your part, either your part in primary care or my part in secondary care, or in fact both of us. There's no way this is linear. So we're starting to recognise that the complete type is almost certainly a vascular injury. The disc happens, bang, the lights go out, the nerves have gone, there's probably nothing you can do. So you refer them and we deal with them, but the chances are that patient has been damaged. What we're looking for is an evolving process, so a slowly progressive condition where the patients recognise some symptoms, you recognise the symptoms and signs and refer them to me, and we can stop progressive damage. So that's the one we're trying to look for. It's difficult, but that's what we're trying to achieve. So complete cauda equina is a mixture of things. As you know, with any syndrome, it's a constellation of symptoms and signs. They usually have back pain. None of these are exclusive, but they usually have quite a lot of back pain. They usually have bilateral leg pain. They sometimes have unilateral, but they usually have bilateral. They will sometimes have bilateral leg weakness, and it's typically just the feet, because the L4-5 and L5-S1 discs are by far the commonest ones to cause this, and they will only affect the ankles and the feet. So they shouldn't have weak hips and weak knees typically. So they've got bilateral leg weakness possibly of the ankle, as I've said. They'll have bilateral saddle anesthesia. Now that may be objective or subjective, and they may describe that. So as I say, you need to ask for that. And typically the neurological pattern in complete is urinary retention, which is painless. Now, I won't give you an anatomy lesson on the autonomic nervous system because I don't fully understand it, but basically your cauda equina tells you when your bladder is filling, so you know you need a wee when you've had too much tea and you sat there cross-legged thinking I've got another 3 patients to see. You sense your bladder filling. You can hold on to it, you can control your sphincter until your 3rd patient has gone and you've done all the paperwork, and then you can get to the loo, hopefully, and then when you go to the loo, you can relax your sphincter and pass urine. And as you're passing urine, you will sense your urine stream, and then when you've finished, you should empty your bladder. So that's normal function. If you lose your cauda equina, you will lose the sensation of bladder filling. Your bladder will fill and fill and fill. You can't open your urinary sphincter, so you don't know you need to go, but you've got a full bladder and then some, so often a litre in the bladder, and the normal bladder contains 500 mils maximum. So you've got a litre in your bladder, you don't think you need to go, but if you do try to go, you can't pass urine. And then eventually your bladder gets so full that the sphincter just relaxes naturally and you get a whoosh and you get an incontinence, which is insensate. So you wet yourself or wet the bed without knowing, and you didn't even know you needed to go. So that's true, complete cauda equina. And as I say, if you've got that, so you'll have numb bum, decreased pinprick sensation perianally, reduced anal tone, and incontinence, the boat has sailed. Almost certainly that patient is already damaged. Now, you need to send that patient to us because medically, legally, that would be wrong, and the patient might have a small chance, but sadly, that's probably too late. And as I say, that may have happened within 5 minutes of the disc protrusion. But that is what it is. What we're trying to prevent is it becoming this. So what we're really interested in is incomplete cauda equina, whereby you may have back pain, but you may not. You may have bilateral leg pain, you may not. You may have bilateral leg weakness, you may not. You're getting the gist now, aren't you? Bilateral saddle anesthesia, urinary disturbance. So what you're looking for is more than one thing. Now, it is a difficult diagnosis. Generally speaking, 70-ish, 70, 75, 80-year-olds do not get cauda equina because it's extremely rare for a patient of that age to have a soft enough disc, to have a big enough disc protrusion to cause it. So it's a sudden compression of the cauda equina. Now, what we're getting thousands of is patients who are 80 with a bit of back pain, a bit of urinary incontinence. They get a scan through the MSK pathway and it shows, thanks to radiologist from Scotland or wherever they're reporting remotely, the patient has severe cauda-equina compression, urgent spinal referral. You then have no choice but to do so, and we get a referral of a patient that's clearly got chronic spinal stenosis that's been 30 years in the brewing, and if they have got bladder dysfunction, it isn't coming back at 85, and so that's not an emergency. But it's a difficult scenario, isn't it? So we're looking at patients 70 and below, really 50 and below, because you're looking for an acute disc protrusion. They've got a new onset of pain. Now, they may have chronic pain with an acute overlay. So sudden increase in pain in the back, sudden increase in pain in the leg. Now, as you know, most patients with sciatica have unilateral leg pain. They have a right or a left-sided disc protrusion. It's not unusual for patients above about 40, 50 years of age to have bilateral leg pain because they've got spinal stenosis. We'll come on to spinal stenosis later, but the spinal canal is oval in shape, and as you become older, it narrows bilaterally into a sort of flattened pattern, and you get bilateral leg pain almost as normal. So again, bilateral leg pain per se isn't a red flag. You've got to have something else. So if you've got weakness of new onset, if you've got saddle anesthesia, that can be unilateral. Ideally, it should be to pinprick, but I don't expect you to do that on a visit when you've got 12 cats and a bunch of grandchildren running around. So I don't think perianal examination is necessary in primary care. I certainly have a bit of a high horse about PRs. When I was a registrar, I used to be quite rude to GPs about, what do you mean you haven't done a PR? And my wife at the time was a GP and made it quite clear that that wasn't reasonable. And when I reflected over the years, it isn't reasonable because I've realised that I don't know what normal PR is on that patient, having never met them before. So I don't want you to consider doing a PR realistically, in the sense that the chances of you being able to tell the subtleties between their normal and their current situation when they're in pain is not that helpful. So the key is the story, as I've said already. So have they got urinary disturbance? And so we've already said what the true neurological pattern of incontinence is, i.e. they're in retention, they don't feel it, and then they have overflow, but that's too late. So what you're looking for is a delay in micturition. When did they last pee? Have you got a bladder scan? If you can do a bladder scan, and some people have got these, if you can do a pre and post void bladder scan, which has become a de facto part of the assessment in secondary care, then you need to do that. And that's really helpful, because if they're micturating to below 200 mils after passing urine, they almost certainly don't have cauda-equina. But this is difficult. So if you've got a patient with new onset of these, a mixture of these constellation of symptoms, that needs to be referred as an emergency. Let us do the worrying thereafter. We've got registrars on call, both at the Hallamshire for neurosurgery and us at the Northern General. We will see the patient, we will scan the patient, and we'll send them home with a reassuring pat if necessary. If they've got raging sciatica, we'll put them into clinic to deal with them urgently. And if they've got cauda-equina, we've got a chance of saving them from a life of disastrous disability. So how are you going to assess that? So the key is history. So we learned this at medical school. How do you take a history about pain? So where's the pain? So this is now about cauda-equina, but also generally, where's the pain? So the nature of the pain can be helpful. As you know from MSK pain isn't felt exactly at the site where it comes from. So patients who've got a bad elbow rarely point at the elbow. It usually comes down into the forearm. As you know, hip arthritis usually is in the groin and the thigh. So one of my bugbears is patients say this, doctors and physios say this patient's got sacroiliac joint pain because they point at their SI joint. Why would the SI joint be different to anything else? Why would it hurt over the SI joint? So SI joint pain is actually back pain. That's muscular pain or low back pain. Buttock pain is common, hip pain is common. So if somebody points to the trochanter, I'm sure you all see thousands of people with lateral hip pain, with trochanteric bursitis, gluteal weakness, blah, blah, blah. But sometimes it can be back pain. So where does the patient explain? You all know about how to get the gist of how somebody describes the pain. What type of pain is it? And the key for back pain is it mechanical or non-mechanical? So in simple terms, if it hurts when they're moving, aches at the end of the day when they've been busy, hurts when they're twisting or moving, bending and lifting, that's mechanical pain. That's a degenerative process. That's not concerning. If it's non-mechanical, so worse in bed, worse when they're sat relaxing on the sofa and trying to be quiet. It builds up or is constant throughout the day, then that is potentially a non-mechanical pain, and that's a red flag, which we'll come back to. So the timing of pain is important. You're all aware of the arthritides even. So early morning stiffness that eases through the morning suggests an inflammatory pathology rather than a degenerative pathology. Associated symptoms, so looking for red flags again. Past medical history, keep coming back to the past medical history, just a little delve into their specific reasons for pain, which brings us on to red flags. There are thousands and thousands of red flags that might be interesting. There are 73 the last time I looked in the literature that have evidence behind their relevance. To be honest, there's only 2 that really matter, which we'll come back to. When I was a lad, we were taught that any child with back pain was a red flag. Bloody hell, if only. My clinic's full of 14-year-olds, 11-year-olds with back pain at the Children's Hospital. It's an epidemic, and the child in this country hasn't changed genetically in the 16 years I've been a consultant. It's almost certainly mobile phones and sitting cross-legged on the bed. But back pain is becoming a problem. So I would say below probably even 10 is a relative red flag, because back pain is really common. The nature of it, so the constant, unremitting, non-mechanical nature, as I've already said. Thoracic pain is a relative red flag, but it's a fairly low likelihood one. Symptoms of fever, weight loss, previous infection. Please, please, please think of spinal infection. If they're really taking a large intake of analgesics and escalating, just think, could this be something more serious than just a miserable patient with mechanical pain? Back pain is miserable, as you know, but just have a think on that. Night pain is a relative problem. Neurological signs or symptoms, as we've already touched on and we'll come back to. And rarely a scoliosis that is very painful could be a red flag. Now, we always used to teach that idiopathic scoliosis in a normal, healthy child isn't painful. Again, cross-reference that with a growing epidemic of mechanical back pain in children. We see lots of painful scoliosis. But this is generally referring to somebody with severe pain in a localized region with the scoliosis. It could be an osteoid osteoma or some other form of tumor, really rare. So the 2 red flags that I want you to take away that are absolutely relevant and will cover 90% of the pathology, at least, that you and we will see, is a previous history of cancer and a previous history of infection, full stop. So if you can ask those 2 questions, you're really sifting out the risks for these patients. So a non-mechanical pain with just that, you're better at this than me, the spider sense is tingling, this patient hasn't been before, or they're using different language from the 17 times they have been before. I'm just not quite sure that this is the same. And oh yes, that's right, you had a kidney infection last month, didn't you? Just think, could this be spinal infection? I'd much rather stick them in the scanner and do a CRP and say, no, it's just degenerate. Hey, excellent, everything's great. If we miss it, they could come in paralysed in 3 months' time with a bag of pus instead of a spine, and we can't come back from that. So just take away previous history of cancer, previous history of infection as your alarm bells for back pain and red flag pathology. So how are you going to assess the patient? So we're taking the history. We know that we're not worried about this patient, or we are worried about this patient. You don't have time to examine this patient in detail. So I have a little bit of an algorithm for how I would do that. So I do this generally sitting, even me, lazy as I am, sat in my clinic, I wheel my wheelie chair around in front of the patient. I've seen them walk in. I've made a start on the assessment. So you watch them walk, if they can walk. You have a quick look at their back. They may have a massive scar. They may have an open wound. Have a quick look at how they move. So I basically say, don't hurt yourself, take your time, but show me how you would aim towards touching your toes. And I'm not interested in the degrees of move. I don't do Schober's test. I don't get me to tape measure out. It's nonsense. But you can tell how a patient moves. Are they fearful? Is there kinesiophobia? So fear of motion, fear avoidance, because that's a yellow flag, which we'll come on to, that may benefit from physiotherapy. Do they bend down and touch their toes avidly and come straight back up? That tells you there's clearly nothing sinister mechanically going on in their spine. It just gives you a sense of what's going on. Is there any obvious tenderness? So tenderness in the paraspinal muscles tells you nothing. But if you're thinking this is red flag pain and they say, I've got thoracic pain, I had my kidney infection last month and I just feel awful, doc, and this pain is driving me insane. If you have a prod down the thoracic spine and you hit a locally tender spot on one of their spinous processes, another alarm bell. Neurological exam, it's difficult. I couldn't remember my myotomes or dermatomes until I suffered 6 months of neurosurgery as an SHO. So I'll give you my quick way of remembering it. To be honest, it's not that important. I don't care whether they've got L4 or L5 numbness, because I'm going to do an MRI scan, which will tell me the answer. But it's just having a gist of whether there's something serious or not serious going on. So just to go back a step, I've not put the slide in I normally do. In terms of examination, if you have a patient who has back pain, no neurological symptoms, and no history of anything red flag, so you're thinking it's mechanical back pain, if they've got no neurological symptoms, so no sciatica, no numbness, no tingling, no pins and needles, you don't need to do a neurological exam in any detail. So all I would do in that situation is get them to stand up, watch them move to see whether you think they need physio. If they're not stiff and not creaking and not scared, they're not necessarily going to get a lot of benefit from physio. But if they're really stiff, they can't bend, or they're clearly scared, physio may be helpful. So you watch them bend and then hold their hands for balance and just get them to walk on tiptoes and walk on their heels. If they tell you they've got no neurological symptoms and they've got no unsteadiness or anything as you walk in with no red flags, they're not going to have neurological deficit, because they would have told you. So if they can heel walk and toe walk, their balance is good, their proprioception is good, their power is good, and their control and confidence is good. That's all you need to do. So if you write can heel walk and toe walk, that is excellent. That's all you need to do. If somebody's got back pain sciatica, and irrelevant to whether they've got back pain. So if they've got sciatica, now that's a neurological symptom. They may describe numbness, they may describe some weakness, they may describe the leg giving way a little bit. But if they've described sciatica, then I would just do the neurological exam I'm going to come on to in terms of the myotomes and the basic exam. If they've got red flags, if they've got non-mechanical pain, if they're describing clearly progressive pathology, then you have to do a full neurological exam and just check whether they've got clonus, whether they've got hyperreflexia, because then you think they've got cord compression, and that's the emergency referral. So that's how I do a neurological exam. That's how I teach my trainees. So back pain alone with no red flags, no neurology, just heel walk and toe walk, that's it. If they've got sciatica, you just want to check the major motor groups in their leg, because a foot drop will alter the speed of your referral, but it's not an emergency. And if they've got red flags, then you want to do a full neurological exam, because you need to have a rough idea whether they've got cord compression as to refer them today, or whether that needs an urgent referral for brewing cancer or something. I hope that makes sense. So old Apley's aphorisms. So in examination terms, any orthopedic MSKs look, feel, move. So you watch them move, you get them to move, and then you move them. So you're looking just for clues about what they do. Do they have a ministry of silly walks? And don't need to go into detail, but Trendelenburg, antalgic, drop foot. There's lots of funny walks. Even if you don't know what's going on, just say unusual gait. You probably know the difference between ataxic. You've seen plenty of people on West Street on a Friday night, wide-based, staggering. You may not know what West Street is in Sheffield, drunken alley in the main part of town. But you've seen them wherever you live. People who have had too much to drink, your wide-based gait to keep your balance. So if you're a myelopathic or ataxic with cord compression, you should be able to spot that, and that's a relative red flag. You look at the alignment of the spine, look for scars and things like that. And just a few pictures just to give you an idea of what you see. So this is the sagittal plane. So sideways view of this young man here. He's got quite significant Sherman's kyphosis, which is a benign condition akin to the other end of the spectrum to scoliosis. He's got an 80-degree kyphosis. He didn't like it very much. It's not dangerous. It's certainly not an emergency, but that might be progressive and might be worth treating that. That's something to send up electively. But there was nothing wrong with him neurologically, and that's an absolute routine referral. This patient's got a funny sagittal posture. Her bum's sticking out a bit. She's leaning forward. Her legs are bent. So she's got an aggressive spondylolisthesis with a sudden deterioration of leg pain. That's an urgent referral because she's in extremis with pain. She's got a weak ankle and a weak foot. So you would pick that up on the funny stance. She would walk with an antalgic gait. She would possibly be weak around the ankle. And when you quickly examine it, as per I'm going to show you, you would pick up ankle weakness and hamstring tightness, refer her semi-urgently maybe because she's in trouble, but certainly not as an emergency. Coronal view, so look at the back. You can see both of those patients are wonky. One's shifted to the right, the one on the left, and one's shifted to the left. They've both got idiopathic scoliosis. Neither of these are in any way urgent, but if they're not happy with their shape, and particularly if they've got remaining growth, so if they're less than 16 as a girl, that's worth a referral to Sheffield Children's, because we can reassure them. There's a brace trial that we're doing now, so we'll be able, if it's a small enough curve and they're young enough, we could offer them a brace, because you may not know, without segueing too far, but bracing does work. When we were training, we were taught bracing doesn't work, it's a waste of time, but there's good evidence now from proper rigid studies that show that bracing does reduce the likelihood of surgery by about 40%. So we're almost negligent if we don't offer bracing to the right patient. So just consider sending up that 12-year-old with a slight kink spine so that we can have a look and at least give them the option. And we're happy to receive referrals at the Children's Hospital if you're not sure. The key test is Adam's forward bend. Just get them to bend forward and touch their toes. And if the spine twists like that, that's scoliosis, because one of those could be a leg length discrepancy on its own. But if you bend them forward, a true scoliosis will rotate. Their back will be tilted and your plate would fall off if you tried to rest it on their back. And this is an elderly patient, so a combined adult spinal deformity. She's leaning to the right and falling forward. Her spine has basically given up. It's worn out on the right side and she's falling into that gap. And she's going to have severe pain, poor mobility. Now, the operation to fix that is hideous, and I wouldn't recommend it to anybody. So we often don't do surgery. But again, you may want to send them up for us to have a review at the Northern General to discuss their options. We've talked about having a quick prod. Don't spend ages examining them. Most people go, ooh, ah, when they want to convince you they're in pain. But you are looking in a non-mechanical pain. In a red flag scenario, is there some tenderness? The rest of the time, it's pointless. Neurological exam. So the dermatomes are different in every single book. Every person that ever taught you presented them differently. That's because every patient is different. So the simplest way to do it, if you feel the need, is from the front is to draw the leg into 4 quarters. So like a cross, like a rugby jersey if you want. And if you go for the middle of those quadrants, so the medial thigh is L2, the lateral thigh is L3, the medial calf is L4, and the lateral calf is L5. So you work your way around the quadrants. And that's because actually the dermatomes rotate around in slices. And so it's confusing. As I said, it doesn't really matter, but you probably feel shortchanged if I didn't tell you about it. So myotomes are more relevant because this is what a patient's going to worry about. So people say to me, oh, my toe's a bit numb, doc. I metaphorically shrug, I reassure them, but I'm not interested in numbness. I'm never going to offer somebody surgery for numbness alone because the risks far outweigh the benefits. So I'm going to reassure them. Weakness, however, is disabling and I would be interested. So you want to test their motor power. You've seen them walk in, so they're not grossly ataxic. They haven't got red flags. So you're not going to put them on the couch. You're not going to undress them. You're not going to examine them properly as you might have done in an exam once upon a time. You're going to do this sitting in the chair. I wheel myself round in front of them and explain what I'm going to do. So what I get them to do is push their knee up against my hand. So I put my hand on their knee and get them to push up against me. So you're doing hip flexion, which is L2. You get them to straighten their leg in that position and try and bend the knee. So resist the knee extension, that's L3. And of course, you're also getting a sneaky peek at root tension. So people don't think you're testing their root tension here. So I can't remember the last time I lay a patient on a couch and did a Lasag's test with a straight leg raising, because everybody knows it's going to hurt if they want to convince me their sciatica is bad. And it does actually hurt if your back is sore. And if you've got a bit of a sore hip, it's also painful. So it's actually not a very sensitive test. So most of us don't do it. Whereas this is a nice straight leg raise in a sitting position. And so that's a useful trick for just gauging root tension, because if they have got genuine root tension, they won't do that comfortably. The ankle dorsiflexion, so get them to tilt their foot up to the ceiling, pull on the foot, that's L4. The big toe, so I flick my thumb like that when I'm teaching in live. I go, so 2, 3, 4 with the leg, and then L5. So the dorsiflexion of the great toe, extensor hallucis longus, is L5. L5 does other things, but these are the ones that are more reliable at pinpointing the actual root. And plantar flexion is S1. Now, in all but the littlest, oldest lady, their S1 is going to overpower your wrist. So you'll virtually never find S1 weakness unless it's really significant. So again, not that useful, which is why I said do tiptoe walk, because that is quite a sensitive assessment. So we've talked about what to refer. and we need to recover the timeline. So what do I want you to refer now? What are you going to want to refer now? Well, somebody with back pain and bilateral weakness. So weakness is a red flag. So if the patient's got significant neurological deficit, discuss it with us. We might say, oh, that doesn't sound too bad. We'll see them on Thursday. So we have in our spine team at the Northern General, we have an on-call system where there's a registrar on call 24/7, so you can speak to somebody on the phone. They shouldn't be in theatre other than in an absolute emergency, so they should be available for you unless they're in like a resus situation. They will then refer to the consultant on call, who is on call for a week at a time, and we have a dedicated programme to be available. So there's somebody to speak to, and we have a twice weekly sort of fracture clinic, if you will, so spine on call clinic. So if we hear a phone call about somebody who's got a foot drop, I'm not worried about foot drop as an emergency, but it is urgent. Patient will be worried, and it might be something more sinister than a disc. So we'll see them in the spinal clinic next Thursday. So we get them up as a hot referral and we can see them. So give us the choice, give us the option by referring it through. A patient with bilateral leg pain and any bladder problems, and this is of new onset. I'm really not interested if it's been 6 months. Send them through the MSK pathway. We'll see them, but there's no urgency. But if you've got a patient with a new onset of bilateral leg pain with bladder symptoms, I've talked about what you're really looking for, but we've also agreed that it's difficult to tell the difference. So if you're worried, pick up the phone, speak to my registrar. We'll help you through the algorithm and give you some advice about what to do. And if in doubt, we'll see the patient. Bilateral saddle numbness, whether objective or subjective, because you're not realistically going to examine them very often. That's a red flag and I want to know about it. Incontinence, as I say, is difficult, but if it's insensate incontinence, that's definitely an emergency. If it's a bit of leaking, well, what does that mean? That's really difficult. And quite a few patients wake up wet in the morning, but it's like every other third day. I really don't know what that means either. But again, let us know about it. Let us discuss the picture and see what we think. So if you want to refer a patient now, then through the Northern General switchboard, ask for the orthopaedic registrar on call, and they will take your call. They may use the emergency department, although at the minute that's difficult. We have the surgical assessment centre, and they will see your patient for you. The difficulty with sending patients through to things like Chesterfield is they don't have scans out of hours, and then they have to contact us and send them through. So if you think it's a genuine emergency, you're probably better off sending it to Sheffield. If it's just for assessment, then a more local hospital is, of course, fine. And some of you may be nearer to Derby and Nottingham, in which case, obviously, you use their service.
Mr. Breakwell, can I just ask a question?
Of course.
Sorry to interrupt. We just had a couple of questions in the chat. Just going back to the last part when you discussed history, you were talking about infections, and you gave an example of someone who'd had a urinary infection and then developed back pain. So the question that we had, Mohammed asked, should we be concerned about any infections? And he wrote, including like an URTI. And then Veronica wrote, how recent an infection? Do you mind just mentioning that? Thank you.
Yeah, great questions. And again, there isn't a right answer always, but so the commonest infection that we see by far is Staph aureus. So it's usually come through the skin in some way. So an open sore, that sort of thing. URTIs are relatively unusual because the bacteria, we rarely see that. Urinary infection, sadly, is quite common. So if you've got anything sort of E. coli type or Klebsiella, they're hideous infections in the spine. They rapidly destroy the spine. So that's the scary one. So gram-negative sepsis is bad. Cholecystitic type problems, diverticular flare-ups, that sort of thing. So in simple terms, yes, any infection. In terms of timeline, it can be months and months and months ago. Now, obviously, if it's 20 years ago, it's probably not relevant. But I think anything within the last 6 months is certainly relevant because there's literature that shows that infections are often missed for more than 4 months. And so I think if there's a red flag type back pain, you know, obviously if you've got a patient who's had back pain for 20 years and they come with their back pain, and had a chest infection, that's not interesting. But if it's a new onset of pain, then that's definitely a question. And if the pain sounds different, so it's non-mechanical, they're not feeling right with it, and they had a UTI 3 weeks ago, yes, just consider it. Now, if you're not really worried, if there's no neurology and they're not sick, the best test to do would be to do a CRP. CRP is extremely useful. It's really sensitive, as you know. and we find it extremely useful, and we use it to chart and trace our infections. So if it's 12, then there's nothing much going on. Spinal infection is usually in the 200s. And so if they've got discitis or osteomyelitis, it'll be that sort of territory. If you're worried that they look sick, they're cachectic and look awful and they're in loads of pain, then give us a ring and we'll see them. And we have a good relationship with infectious diseases to manage them either on the ward at our place or at the Hallamshire, and we use OPAT and things so we can manage them in the community.
Thank you, that was so useful. And yeah, just following on from the examination that you've been talking about, Wala Saeed has asked, would you just mind just going over, because I think this will be so useful for us all, the leg myotome examination. So when they're sat down, just exactly what, do you mind just saying what exactly leg movements we're just doing? That'd
Absolutely.
Be okay.
So
thank you.
Yeah. Excellent. No, so I mean, obviously this is much easier to do. I always pick a in a room. So if you imagine you're sitting in front of somebody, you wheel yourself around the side of the chair, you've got them sat upright in front of you, and I get them to put their arms on the arms of the chair out the way, and then basically you go up to them and you test both of the legs. So I put my left hand on their right knee in front of me, and I say, push your knee up against me. And I'm trying to push down on their knee. So they're flexing their hip as in that picture. And that's L2.
Great.
And so I have my rhythm the way I do it. I do right knee, right knee. You know, I go through rhythm. That really doesn't matter. So push up against my left hand with your right knee. Push up against my right hand with your left knee. That's L2. Then I sort of back out a little bit and I say, okay, kick your leg out straight. Keep it straight. Don't let me bend it. Okay. So I put my hand behind their knee and then my hand on the shin, and I'm trying to bend their knee. So that's the words I say, kick your leg out straight. I watch what they do, and if they wince, I get a suggestion that they might have hamstring tightness if they're a young, fit, athletic person, or they may have sciatica. So if I'm asking about a sciatic patient, they go, oh, bloody hell, then you think, oh, that's root tension. If they kick their leg out straight and hold it there, then they've already got anti-gravity grade 3. And then, as I say, hand behind the knee to support the leg, because you want to help them. And then push down on the shin, trying to bend the knee. Resist me, don't let me push down. Great. So that's L3. And then whilst I've got the leg in that position, I sort of carry on holding it. I say, pull your foot up towards you. So foot up towards your nose. And then I pull on the foot. So you can see the foot is dorsiflexing. So pull the foot down.
Okay.
And then I say, toe up towards your nose. So they pull the big toe up towards the nose and pull down on the big toe, which is L5, and then push me away, S1. But as I say, that's not that useful, S1. So 2, 3, 4, 5 is knee, hip, knee, ankle, big toe. 2, 3, 4, 5. And then if you trying to remember it, the big toe is thumbs up is 5. So if you think that as your big toe, that's L5. Does that make sense? Is that clearer? Is that clear?
No, that was really, really useful. Thank you so much.
I haven't been asked to talk about neck pain. Pretty much everything I've said about back pain is equivalent in neck pain. Pretty much everything I've said about sciatica applies to arm pain. And pretty much everything I've said about cord compression and stenosis is the same for myelopathy. And I think it's important to just touch that. So in terms of neurological exam for the upper limbs, same thing, I'm sitting in front of them. So get them to sit with their arms, with their elbows bent to 90 degrees. And you push down on their hands with their elbows flexed. So that's biceps. So that's C5. Now I cheat. I wouldn't pass an exam anymore because I then do triceps, because I do biceps, triceps. So that's 5 and 7. But because my hands are there in that position, that makes sense to me. So 5, 7, and then dorsiflexion of the wrists is 6. So cock your wrists up towards you, keep it there, don't let me pull it down. And I'm pulling against that dorsiflex wrist, that's 6. So 5, 7, 6. And then squeeze my fingers. So I hook my fingers and try and straighten their flexed fingers. That's 8 long flexors. And spread your fingers out wide, keep them apart, don't let me squeeze them together. Abductors is T1. So 5, 7, 6, 8, 1. Does that make sense?
Yeah, that's so good. Thank you.
So again, I don't often do arms and legs together because I'm usually doing a neck or a back, but obviously you can do both. And it's 30 seconds. And if you just do it a few times, you'll get into a rhythm, and it's quite quick and quite easy to do, easy to show you. There's actually, I did some videos for Derbyshire, and they're on YouTube. So if you gargle, if you want, if you Google me and Derbyshire and back pain, there's a set of YouTube videos, and there's one on examination there, and there's me pretending to do an examination if you want to have a look at it. It's just easy to see, perhaps.
Yeah, that'd be brilliant. Thank you.
So any other questions, or shall I move on?
Yeah, no further questions in the chat at the moment. So yeah.
Okay, thank
Carry
you.
on. Thank you.
We're now on to urgent referrals. So somebody with a tumour, so they've got past history of breast cancer or prostate or lung, and they've got non-mechanical back pain, but they've got no neurological symptoms, no neurological signs, and they're not ill, and they're not in absolute agony, then that's an urgent referral. So you can send it through saying, I picked this up, I'm worried about this, we'll see them quickly and we'll get them assessed. They're often known to Western Park or the equivalent, but sometimes you'll pick them up for the first time because they were discharged 7 years ago, and unfortunately there's a recurrence, and that can be sent through as an urgent referral. Obviously, if they've got neurological problems, if they've got ataxia, if they've got signs of cord compression, that's an emergency. So no neurology, you can send it through. Infection, we've kind of touched on. So past history of cancer, red flag. Past history of infection, red flag. Signs of infection, systemic symptoms with their back pain. Again, if there's query of infection, but there's no neurology, maybe do a CRP and refer it urgently, and we'll see them within the week or so, and we can pick up and do a scan and take it from there. Trauma is difficult because it's such a wide thing, but if they've not come through ED and not been picked up and they've come to you, the likelihood is it's not a serious level of trauma. But if you've got a relatively minor trauma and they've got back pain and it's not settling, they could have a wedge fracture that's not been picked up, then again, an urgent referral would be entirely reasonable. Obviously, we haven't got time to go through how you manage osteoporotic vertical compression fractures. That's a whole week of lectures. Obviously, that can happen with no history of trauma. So you've got, I'm sure you've been bombarded with the osteoporotic drug people about loss of height, change in shape, blah, 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 blah. It is difficult. But again, if they're in lots and lots of pain and you think they might have a vertebral compression fracture, don't do an X-ray. There's not really much use. Refer them up and we can assess them. There are treatments such as vertebroplasty, which is really rare to be relevant. To be honest, it's not been the answer we'd hoped for, but it does suit some patients. So give us the chance to consider it. Again, in the absence of neurology, that doesn't need to be as an emergency, but can be urgent. Non-urgent referrals, so elective referrals. So you've got a patient with back and or leg pain, as I say, synonymous with neck and or arm pain. Ask about where it is and when it happens and what else is going on to make sure it is a non-urgent problem. So there's no red flags behind it. There's no neurological signs behind it. So where's the pain? Is it in their low back, radiating to their buttock and down the leg? What can and they can't they do? Because that will obviously gauge the level of urgency in that patient. Because obviously one patient with sciatica deals very differently with another patient with sciatica, depending on their job, their childcare situation, etc., etc. Can they stand? So if they're stenotic, standing will be the problem. If it's sciatica from a disc, it's more often that sitting is the problem. So again, the subtleties can sometimes tell you. Walking, for me, if a patient can't walk 400 yards, that's quite disabling. If you can walk more than 400 yards, then it's down to a quality of life thing. So you get the Derbyshire walkers, oh, after 5 miles, my leg aches a bit. Off you go. I can make you a lot worse than that with surgery, sir. Goodbye, come back when it's worse than that. And they don't like that, but, you know, we really shouldn't be operating on people like that. But if people can't walk 400 yards, that starts to eat into their independence. And some people can't stand for more than 10 minutes or walk for more than 10 yards. That's an urgent, relatively speaking, stenotic problem. The diurnal pattern of pain can be helpful, as you know, and these are just the useful bits. I just tend to touch on yellow flags. You're more appropriately trained and more experienced in this than me. I'm an amateur psychologist as a spine surgeon, but I'm nowhere near as good as you guys. But yellow flags are important in back pain because one of the commonest things we get, as you know, is the concept of pain being dangerous. Oh, it's the spine doctor. Yes, I'm aware of that. That's what I do for a living. And people are really worried that spine pain equals badness, and they go into a spiral of lack of movement, and of course their back then gets worse. They stop doing exercise, so their back gets worse, and then that is a self-fulfilling prophecy. So it's really important to look into their ideation. You all know about inappropriate illness behavior and partners and things that feed into it. We don't see a lot of compensation psychosis in this part of the country, really, but you always have to think about that. Slipped over in Sainsbury's last week. Yes, okay. Mood is a big one. So you all deal with a lot of mental health, and back pain is inextricably linked with mood. And that's a real problem for them and for us, and sometimes employer issues, etc. So that's just an important thing to work through in terms of their fears. And in Sheffield, we have, if you're familiar with the Sheffield Aches and Pains.com website, there's our MSK system and the referral pattern. There's a nice method of assessing the yellow flags in terms of their risk of chronicity. And you're probably aware of the start back, which is, again, a useful tool for just gauging how likely is this patient to become chronic, because as you all know, they're a massive drain on the NHS and are disastrous for them. So if you can stop them deteriorating, that's definitely worthwhile. So in terms of their back pain, if it hurts more on flexion, that could be coming from the disc. If they're standing and they get pain as a band across their lower back and into their bum, that could be stenotic pain. If when they sit, it could be their facet. If they're lying down, then it's possibly non-mechanical pain. The reality is that's all bunkum. Back pain is usually undiagnosable. It's the nature of the pain is the key. So don't worry about, is that discogenic pain? Is that instability pain? Because none of that means anything. The key is it scary pain? So is it non-mechanical? Is there a red flag history? Is there something just tingling your spider sense about this patient amongst the 23 others you've seen with back pain this week? Is there just something not right? That's the key. So we talked about the dermatomes and myotomes. Now, what sciatica does is ignores that. So because sciatica hurts in a primitive way, it hurts in every tissue. So it isn't just the bit of skin that hurts. So this is the thing that often is hard to get your head around. So I've told you that the lateral calf is the L5 dermatome. So why doesn't sciatica from L5 just hurt there? Well, because there are other tissues involved. So if you go back to your embryology, and I'm about to give you an hour's lecture on embryology, no, don't panic. If you go back to your embryology, when you were really small, you had something called the sclerotomes, which is the stripes on your rugby jersey, which was T3, T4, T5, and the somites formed. And every tissue that created a T5 has a T5 innervation. So if you're talking about L5, that's the periosteum of your femur, some of the capsule of your hip joint, some of the capsule of your knee joint, some of the tissues in your tibia. So that's why L5 pain hurts like it does. So don't worry about the dermatomes when it's pain. So there's 3 common presentations of sciatica, and actually there's 2 common. L4 is pretty rare. L4 is pretty consistent. So if a patient's got pain in the green stripe going down to the medial ankle, there isn't much else that can cause pain like that. So pain down all the way down the leg, unilateral, down the front of the leg into the medial shin as far as the ankle, that's probably L4 pain. And that's relatively uncommon, but it is fairly consistent. The commonest is L5. So they typically have pain at the bottom of the back, top of the hip, top of the bum cheek. And then it goes all the way down the outside of the leg, outside of the thigh, outside of the calf, top of the foot, typically to the big toe, as in the blue stripe. And that's 60-70% of patients with radicular pain from either slip disc or from stenosis will have L5 pain. So you commonly get your 75-year-old chap comes in, when I stand, my leg hurts, where does it hurt? And he'll draw that blue pattern for you. Bingo, L5 stenosis, commonest thing that I treat. Fine, send him up. We'll scan him and we'll operate on him if necessary. S1 is quite common too, and that follows the red line. So bottom of the bum, in your bum cheek, in the crease between your buttock and your thigh, all the way down the back of your leg to the heel, and typically the lateral border of the foot. Now, as you said before, everybody's dermatome is slightly different, so don't worry about the niceties at the bottom. And again, it doesn't matter. I don't care if you get L5 or S1 wrong. If you've got a patient who's in real trouble with their leg pain, it isn't getting better, they're struggling to work, they need to go into the system to be scanned and seen and given the choice of treatment. So just some basic details. If you're 16 to 50 years of age, and I've less that now, so hopefully I'll not get a slip disc. If you're 16 to 50 years of age, you'll get a slip disc and sciatica. Above 40, you'll get spinal stenosis. Now, it's not as hard and fast as that, but that's a rough guess. Typically, sciatica pain is shooting, intermittent. It builds up when you're moving, and it's also horrible when you're sitting. So sciatica patients sometimes choose not to sit in clinic. They'll lean on the back of the chair, or they'll sit leaning over like that to get off the leg, as opposed to a stenotic patient who's pain-free when sitting. It starts to build up when they stand, carries on building up when they walk, and they have to keep stopping to allow the legs to settle. So radiculopathy, so sciatica, shooting, impulse pain, worse when sitting, stenosis, aching, either pain coming up from the bottom or down from the top. My feet feel a bit dead, my legs feel a bit heavy, I can't get my legs going once I've been walking for a while, and definitely typically worse when walking. In the olden days, patients used to report they could walk 100 yards and cycle 10 miles. Most old people who were on the bike have now been killed and knocked off in Sheffield particularly, so you don't get many little old men on their bikes anymore, but they'll commonly describe they like to push the shopping trolley in Asda, so they'll go shopping as long as they can push the trolley because they're in the cycling position, leaning forward, and they can keep going all the way around Asda on the trolley, but they can't stand up and walk carrying the bags because they're opening up their spinal canal. So when they go for a walk, they may stop and sit on the wall, they may lean over the garden fence and talk to their mate, they may bend down and tie their shoelaces, and they may walk like an ape with a bent knee and bent hip to open up their spinal canal just that little bit and get rid of some of their leg pain. So that's a classic sign of spinal stenosis. Just some simple bits of sort of takeaway numbers just to get your head around and just to help with reassurance. Most of the patients you're going to see with back pain, leg pain, neck pain, arm pain, they've got nothing wrong with them. They're not serious. They're not in any danger. So lots and lots and lots of reassurance. And again, this is what you're good at. You're brilliant at safety netting and feeding people through the system as necessary. So in a disc herniation with sciatica, if it's their first episode, 90% are going to get better and stay better. So you can reassure them in the next 6 weeks or so, your pain will go away almost certainly, and you'll go back to normal and it'll never happen again. So off you go, take your painkillers, keep exercising. And if it hasn't gone by 6 weeks, come back. And most people will take that. If it's their second episode, 90% will get better, but this time there's a higher risk of it happening again. And on their third episode, 90% is going to get better, but it almost certainly will happen. Most of these will get better by 3 months, and certainly most of them have turned the corner by 6 to 8 weeks. So as you can see, any episode of sciatica has a 90% chance of resolution, but it's increasingly likely to recur the more often you have it. So 10% don't recover, if you do your maths, and of those, 90% will get better with surgery. So that's the 10% that need to come to us eventually if they don't get better. In terms of back pain, nice guidance, quite rightly and happily for us, says don't operate for non-mechanical back pain. Woo! Finally didn't need to do any fusions, which is miserable for me and miserable for the patient. So we only offer back pain surgery if there's red flags. If there's yellow flags, sometimes it's worth you sending them to us to review them, to stop them cycling through the system. So if you've seen them 25 times and they just don't take your word for it that there's nothing wrong with their back and there's loads of yellow flags, send them to us, we'll stick them in the scanner and we'll reassure them, and that might help. All I ask is just send an honest letter. Don't bullshit and say, oh, they've got numb bum. We'll see them. If you just say, patient cycling, they've been coming back, they're really worried, lots of yellow flags or words to that effect, we'll happily see them, we'll happily assess them, we'll happily scan them and send them on the way. A scan is 250 quid in the NHS. It's a lot cheaper than 20 appointments with you when you haven't got any. So just keep that in mind. In terms of surgery, there are some forms of mechanical back pain that are not non-specific. The NICE guidance was a sort of double negative. You can't operate on non-specific mechanical back pain, but they might have specific back pain. So they might have a spondylolysis, they might have a spondylolisthesis, they might have an instability. Don't worry about the detail. But you're only going to offer surgery to somebody who's a motivated, active individual with a relatively short history of back pain, who's got mechanical pain with nothing else. So if you've got a 35-year-old, active gym person who works, but has got really disabling levels of back pain and they've been through physio and it hasn't worked, consider a referral because they might have a spondylolysis that might respond to treatment. And the MSK pathway should have seen them and should have scanned them because they're not responding and we should have picked that up. But if they haven't, consider referral. So when
Mr. Breakwell, sorry,
yeah,
can I just ask a question from the chat? Just
yeah.
it was a comment about the MRI that you mentioned, and Karim has just asked, what about MRI indications for back pain?
Virtually none is the simple answer. So red flags, and basically that last person I was talking about. So if you're just talking about back pain, the only indication for MRI for back pain is red flags.
Yeah.
Spinal deformity, so funny looking shape, and in the handful of patients who fit that third line on that, so motivated, short history of severe pain, which is genuinely mechanical, where they might have something like a lysis or a degenerative spondylolisthesis that might respond to surgery, because injections, surgery do not work for back pain. So an MRI is not necessary. And what's clear from the literature, it's not so much a problem in this country, but definitely the key from the literature is MRIs for back pain generate more pathology because people chase the pathology. So you got black disc disease, therefore you get a fusion. So that's, as I say, doesn't happen in this country, but it often actually upsets the patient more because now they read the report. And as you've seen, the reports are detailed and the radiologist will say, right L4 for foraminal stenosis, left L3 for lateral recess narrowing, annular tear. That scares the bejesus out of patients. They think the spine's falling apart. These things are technical language that don't mean much to you, frankly, with respect. They certainly don't mean anything to patients, but they terrify them. So you don't want an MRI in a patient with back pain. So life isn't simple, and I get that. But in a lecture, the indications for MRI in back pain is red flags, deformity, really. So infection, tumour, or query neurological symptoms. So as I say, if it's just back pain, it's really for red flags.
Okay, that's really useful. Thank you.
I know that's difficult for you. Now, obviously, in my private patients, I have a constant battle because they expect an MRI, and I actually say to them, look, I have a standard spiel, but I say, you don't need an MRI because I'm happy you've got nothing sinister. You don't need an MRI because I'm not going to offer you surgery. But ultimately, if you want one, you can have one because you're a paying customer. But I'd advise you against it because you might see this, 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 and this, and you really don't want to know that. And I suggest you go off and see my private physio who will make you better. But it's fine. If they want an MRI, they have to pay for it. And then I get to see them again and they have to pay me again. So it's great. It's fine. But it's not good medicine. And I try to tell them that. But it's a different engagement. Whereas as an NHS patient, I can generally say, you don't need an MRI. It's not appropriate. But as I said earlier, I sometimes do it because I can see they're not going to go away. They're not happy. And an MRI has some relevance at reassuring there isn't that cancer that they think because their auntie died of cancer of the spine. And so just working out what's going on in their head sometimes.
No, that's really useful. Thank you.
So I hope that was an answer that meant something. So non-urgent referral of leg pain. So your MSK pathway is there. It's written and it is what it is. So generally refer between 6 and 12 weeks because of pain persistence, because they're drifting into that 10% who aren't going to get better. If they've got motor weakness, as I said, I'm not too worried about the big toe because nobody generally other than a ballet dancer is going to complain that their big toe isn't strong enough. But if their ankle is weak or their knee is weak, that is disabling. And of course, there are factors like self-employed, single parent carer, carer for their elderly parent. These are factors that are different to the bog standard patient with sciatica. If they're off work, of course, there's a risk of losing their job. That's a relative indication to refer earlier than somebody who's functioning, who's working, who's not got yellow flags, who's managing their life, leave them a bit longer. And as I said before, in a stenotic patient, so your 70 plus patient who's got right, left or bilateral leg pain with no red flags, no neurology, and can't walk 400 yards, you may want to then consider referring them. So just to reiterate, I want you to refer now for cord compression and cord requiner. I hope you're slightly more knowledgeable about cord requiner than you were, probably more scared and more uncertain because I know less about cord requiner than I did 16 years ago. I thought I knew it all, typical surgeon, when I became a consultant, and now I know nothing. And we scan 5 people a day at the Northern, and we pick up about, we're doing more cord requiners than we used to. We're probably doing 1.5 patients a week. Obviously we don't do a half patient, but statistically. So it's still pretty rare. So 5 scans a day for 1 patient a week. So we reckon So it used to be a badge of honour to have a 90% hit rate with corduraquina. And what we now know is that we missed loads if we did that way. So now it should be a badge of honour to have a 10% at most hit rate, because otherwise you're missing them. So we expect between 1 in 10 and 1 in 20 scans to be positive to find that needle in the haystack. So how the hell you're supposed to know, I don't know. So try and use that algorithm, your spider sense, which is what you're good at, and just think there's something different. Be honest with us on the referral. It's much easier if you're honest, and we will see them. If you get any, pardon my French, shit from a registrar, you let the consultants know, because they're told not to refuse referrals, to have to be constructive. And if they don't need to see them, they'll see them in a spin-off. And of course, they're responsible for that. But if in doubt, speak to us. Urgent. So if a patient's in extremis, so as we sometimes call it, status sciaticus, so that patient who's curled up in the embryonic position, not embryonic, the fetal position on a bed, can't move, can't get out of bed, that's just a disastrous situation. We can see them more urgently. We can offer them treatment options. I saw a guy on call this week. I was told he was on his own yoga mat. I thought, what's that mean? So we opened the curtain. He was a Muslim guy, and he was on a mat on the floor. I thought, oh, sorry. I thought he was praying. I thought, hold on a minute, that's a black mat, and it's definitely not pointing east. And I said, oh, it's a yoga mat, isn't it? And he was crouched down in almost like a praying position, because he was in severe pain and he couldn't move. And he just cocked his head up and talked to me from this crouched position for about 10 minutes, which is really weird. But he was definitely in severe pain. But I told him that there's a 90% chance he was going to get better in the next few weeks, told him the risks of surgery. We did a scan and showed him that he got a simple slip disc, and he chose not to have surgery and go home. He said, I'd rather manage at home, knowing what you've told me, than to have an operation. Thank you very much. And by day 3, he was already turning the corner. He was better. So that knowledge, that reassurance can make some people make an informed decision. So unilateral weakness, minor motor weakness, and red flags without cord compression, etc., consider an urgent referral. So pick up the phone and speak to us, or send an urgent letter through. We will triage the patient appropriately. Routine, as we said, so back pain with concerning features, leg pain that isn't settling, because most will settle. And the key is reassure, reassure, reassure. Use your pathway, use the resources on things like achesandpains.com. And you must have similar. And as I said, I've done videos before, so have a look at those. You might find them useful. And just to try and pick your way through this morass of patients with back pain, trying to find the needle in the haystack is not easy. So I hope that was useful. I'm happy to answer any questions. You've had some good questions already, and we've got a few minutes left. But thank you very much for your attendance on a cold evening.
Thank you so much. No, that was really, really interesting. So we have got a few questions come in. And just to ask you quickly though, about the case that you just mentioned there, where you saw a gentleman in severe pain, what analgesia do you find the best in that kind of situation?
Yeah, so we use a cocktail. So I would always recommend sort of paracetamol and codeine as a regular safe thing. If appropriate, we use anti-inflammatory. We tend to use naproxen in the hospital. That's the one they seem to like. I'm a big fan of gabapentin. I know it's a difficult drug, certainly in primary care, and it doesn't suit everybody. But in acute situations, we use it quite a lot, and it does seem to work well acutely. From primary care point of view, I would nearly always use amitriptyline. I mean, obviously, you'll all have your experience, but most people tolerate it. It's nice and cheap. It's well experienced drug. And you often find that 10 milligrams of amitriptyline is just enough to keep them going, get them to sleep. Mm-hmm. But acutely, opioids are pretty useless. Opiates are pretty useless. So local simple drugs. And as I say, worth trying gabapentin. I'm sure you've all tried diazepam. For some people who are really agitated and a lot of spasm, diazepam can help. But obviously there's a short time span on that.
Mm-hmm. Oh, thank you for that. And Karim has just asked, would you mind just mentioning spondylolisthesis in GP? He said, would you just brush up on it?
Yeah. Okay. So there's several types of spondylolisthesis, but there's only 2 that you're going to see. So there's degenerative spondylolisthesis and lytic spondylolisthesis. So degenerative spondylolisthesis is by far the commonest. 42% of 70-year-olds have a degenerative spondylolisthesis. So it's synonymous with grey hair and aging. So it's not abnormal. So it's, again, that's why we sort of say don't do MRIs for pain, because then you've got a degenerative spondylolisthesis and you ask what does that mean? So degenerative spondylolisthesis is a normal variant in the degenerative process of aging, and it's often not painful. However, it can be painful. It can cause back pain because it's only caused by arthritis of the facet joints. So what happens is your facet joints wear out, and it happens to people whose facet joints are pointing more front to back than side to side. So if your facet joints point front to back, and as they wear out, they slip like that. So gravity, as you lean forward, your body wants to fall off your legs, and the joint can't stop you. If your facet joint's that way and you lean forward, they're going to stop each other. But if your facets are sagittally aligned, so it's a genetic variant, and your body allows that vertebra to slide forward. And the gist of it is that your L4 canal, try and do it in a side, you can see, your L4 canal is like that, and your L5 canal is like that, and your nerves run through the gap. When your L4 slips forward on L5, as it does in a degenerative spondylolisthesis, you get that effect. So you get a chicane effect. So your nerves have to go round the corner. So it's a common cause of stenosis. So 50 plus bilateral leg pain of gradual onset, of a mild to progressively worse nature, typically almost always L5, so pain in the bum, lateral thigh, lateral calf, worse on standing, eased by sitting. Then they might have a degenerative spondylolisthesis, and they often do very well with the decompression. But per se, it's not dangerous, it's not unstable, and it's not a risk, but it might be painful. We don't treat, in Sheffield anyway, we don't treat back pain coming from it because it doesn't get better. So we don't do fusions for back pain. Lytic spondylolisthesis is different. So the spondylolysis, as it's called, is the stress fracture in the pars. Now, if you don't know what the pars is, I can't explain it without a diagram, but it's the bit of bone that connects the two facet joints. So each vertebra has a disc between it and its mate above, and a disc between it and its mate below. Each vertebra also has two facet joints, and it has a hand that goes up. So if we're talking about L5, it's got a hand that shakes hands with L4 at the facet joint there, and a hand that shakes hands with S1 down there. Now, the bit of bone that connects these two bits is called the pars, and it's just a little bridge of bone. And you can't see it on an X-ray because it's at 45 degrees to the X-ray. And so some of you may have heard of the Scotty dog sign. That was the old test we used to do. You do an oblique X-ray and look for a Scotty dog. Don't worry about it. So that gets a stress fracture in that bit of bone, typically as a child. So somewhere between the age of 6 and 15, the patient gets a stress fracture. So you know what a stress fracture is. So the bone's bendy in a kid. They jump up and down playing tennis too much, or netball, or gymnastics, or fast bowling. And the bone does that like a paper clip, and at some point it separates. There's not a big bang. It's not a fall out of a tree. It's not a fall off the bike. It's a stress fracture. So it just happens. More often than not, it's not painful, and more often than not, that lysis heals. So if you see a kid with acute onset of back pain who's a gymnast, they may have a spondylolysis. It'll almost certainly settle, and you don't need to worry about it. In some of those people, the fracture doesn't heal, and it remains a gap, and it's scarred up, and it isn't painful, but it wobbles slightly. And over the next 30 years, that L5 wobbles more on S1 and wears the disc out faster, and they typically present between 35 and 45 years of age with a new onset of sciatica, and it's nearly always L5, and you do a scan, and you've got a lytic spondylolisthesis. A what? Did you know about that? No, I didn't. And it's the first time anybody's ever noticed. We get a steady trickle of children with lytic pain that don't settle. So if you've got an active child with localized right-sided or bilateral low back pain on activity that isn't settling, they might have a spondylolysis. That's an indication for referral to the children's hospital. They're often extremely sporty, so football academies, gymnasts, the regular swimmers and divers, and they're usually active, and they get a stress fracture and it's painful. We nearly always treat it conservatively, and it heals and it goes away. So some of them don't heal and then go on to develop a spondylolisthesis. When the disc wears out slowly, the bone slides forward. It's extremely, extremely rare for it to be in any way dangerous. In a handful of children, they're basically L5 continues to slip and drops off. And that's a horrifying, terrifying, rare thing, and don't need to worry about it. So spondylolisthesis isn't dangerous, it's not risky, but it can be painful, typically with sciatica. So you've typically got your 40-year-old with a new onset of sciatica and they've got a lytic spondylolisthesis. And when you dig back, they may say, oh yeah, I did have a bit of back pain in my 20s, but I didn't think anything of it. And then you've got your 70-year-old, 80-year-old with relatively new onset of stenotic pain with a bad, creaky, stiff back, and they've got bilateral L5 stenosis. Actually.
Thank you. Yeah, no, that was really, really clear. Yeah, thank you. And then we've just got a question from Akeem, and they've said...
Is that the X-ray, standing X-ray?
Yes, thank you. Can you see it?
I
yes,
saw that one. Yeah, that
X-ray.
one was
yeah, brilliant.
Yeah. So, so just to expand on that, Akeem, that's a good question. There is, in general terms, no indication for an X-ray in back pain. So a back pain, if a patient's got back pain, you do an X-ray, you've got about a 1 in 1,000 chance of picking up a pathology. So X-rays per se for back pain are not relevant. However, if you've got somebody with significant red flag pain, that might be useful. If somebody's had significant trauma, clearly that's useful. And somebody who's changing shape as a little old lady, it may be useful to screen them for osteoporotic fractures. Your specific question is any value in lumbar X-rays in ED following falls from a standing height. So I guess the answer to that is it depends on the patient. So if you've got a 20-year-old who's fallen from a standing height and got a bad back, if there's no red flags, then no, there's no indication because they won't have a fracture. And if they do, it's the tiniest little crack that's of no relevance. If they're 70, then, and they've got back pain, they might have a fracture because they're more likely to be osteopenic stroke osteoporotic. They may have other pathological processes, so they've fractured through a tumour. So I guess it depends on the degree of pain and the degree of disability, if you will. So when I teach registrars, you don't need to worry about the specifics, but there's a really brilliant little sentence around what is a stable and what's an unstable fracture, and it's called White and Punjabi's definition. Don't worry about that. But when we look at scans, it's like, oh, is that stable? Is that unstable? A stable fracture can be considered stable when it doesn't increase in pain, when it doesn't increase in deformity, and you don't increase neurology under physiological load. So you've got a broken bone, let's say a burst fracture of L1 when they've fallen off a ladder, and they're in a bit of pain, and they've got no neurology, and their spine is spine shaped. If when they sit up, and we do a sitting X-ray or a standing X-ray, the spine is still spine shaped, they've got no neurology, and their pain is still acceptable, that fracture is stable. So expanding that to your scenario, if you've got a patient who's fallen over playing football and they've got pain in their back, but they walked into ED and they've gone and got a coffee while they've been waiting in ED, and you've got them up and you've stood them and they've heel walked and toe walked, then they've got a stable fracture at worst. And so, no, you don't really need an X-ray. But if they're hunched over, if they can't get off the couch, if they won't move, then an X-ray has some relevance. So it's horses for courses, I suppose, in ED. But in primary care, certainly you don't need an X-ray for back pain. And they won't do one if you ask for one.
Yeah, more to the point. So I think this will be our last question, actually, looking at the time. So Karim's just said, which is the best modality if worried about METs?
The best modality of imaging, was that?
I think so, yeah.
MRI. So we don't use CT scan very often other than for trauma. When we use a CT, it's much more about planning technical aspects of surgery. So for us, an MRI is the king. An MRI is really good for early METs. So you're probably familiar with the concept of T1 and T2 weighted scans. Again, don't worry about the detail. But a T1 scan, where most things look black, is really useful for picking up little tiny spots of METs. So if you've got that patient with previous history of prostate cancer who's getting worse back pain, PSA's gone up a bit, we'll get an MRI, and they may have multiple METs, which obviously changes their management. If you've got signs of red flag modality and neurological symptoms, then a scan is really good at identifying the instability of the fracture, because the fracture will be edematous, shows cord compression, and that then tells us when we need to get involved as surgeons and operate, or if we send them over to oncology direct. So we have a very good relationship in Sheffield with Weston Park, and patients go both ways, and an MRI is definitely the key.
That's brilliant.
Easy to arrange and quick, and it's cheap.
Thank you so much.